Dr. Rakesh, it's now being live streamed on YouTube. You can start the things.
Thank you so much, and welcome all for the webinar series of ISA-IJA Research and Publication. Thank you all, and thank you ISA National Headquarters also for all the support for this academic webinar series related to all the concerns of research and publications. So let's welcome our chairperson for today's webinar, which is primarily based on a very important topic, how to choose a study design. And today's session will be chaired by Professor Pankaj Kundra. He is Pondicherry. Sir has been an excellent academician and researcher with many of his laurels and credits to him. He has been orated to many of the conferences, the reputed orations, as well as he has a number of research publications, and is also the editor of Indian Journal of Anesthesia. So welcome, sir, and over to you, sir.
Thank you. Thank you, Dr. Rakesh, and thank you, Dr. Bajwa as well. Well, it's my honor and indeed a pleasure to introduce Professor Anju Agarwal. She's a well-known personality all over India as well as abroad. She is currently working as professor and head of Department of Anesthesiology and Critical Care at AIIMS, Bhatinda. She is also the Vice President of Research Society of Anesthesiology and Clinical Pharmacology. She was former editor-in-chief for the Journal of Anesthesiology and Clinical Pharmacology. She also is the president of ISA Punjab chapter, and in addition to that, she is National General Secretary for Association of Obstetric Anesthesiologists in India. She has over 90 indexed publications, about 12 chapters. She has many other laurels, which I may not be able to cite, because let's give the mic to her for doing the job for which she has been invited to do. So Dr. Anju, over to you, and it will be always, as usual, a pleasure to listen to you and learn from you.
Thank you so much, sir. Thank you so much for such a generous introduction. I barely measure to those words. And indeed, I see on the webinar and live up here, many stalwarts, and from where I think we all can learn from each other. My talk would definitely be a very basic talk, just to introduce the study designs to the researcher that we have, especially the young researchers that we have in the audience. I would like to have inputs from stalwarts. We have Dr. Pankaj Kundra, Dr. Rakesh Kar, Dr. Bajwa, I see Dr. Narayana, Dr. Tejkal sir. Thank you so much, sir, for joining, and a host of many stalwarts up here. So as I take you through the study designs and how to choose the study design, I would actually be looking at the basic concepts that are important for us. And I'll have to, forgive me for my throat. So basically what we are looking at is, we all understand that research is a systematic method for learning new information. And we're looking at what we would be looking at how to, evaluate and how to, design, especially the unfiltered information, the information that comes from case reports, case control, cohort studies, and how do we go about, and what are the kind of things that would be questions that we would be asking as research questions that would fit into various research designs. We all understand that an approximate answer to the right problem is a better deal than an exact answer to an approximate problem. And therefore, let's try and answer a few problems. Before we choose any study design, we first need to, at the outset, need to identify a research question. And what is a research question is basically either it could be a clinical dilemma or a problem that you want to go into details with and get your answers. Or, you want to find solutions, and of course, you want to make it pretty, clear and specific so that you're able to design your study that answers your questions with full validity up there. So just to give you a brief overview of how do you go around formulating your research question. I know as students, most of you are assigned a thesis, you're told get a thesis topic and you are clueless. So the best thing is to discuss with your supervisor, and then they would give you a topic that must have been there in their mind that they would like to get answers to. And of course, you would be sent to do a literature search. Literature search by itself is a big topic in itself. But of course, we need to learn, and it's a good idea to attend a few protocol or research methodology workshops. I'm happy to see that NMC does have a research methodology module now encompassed during their training of the MD student. So after a thorough literature search on that particular topic, we should be able to do a kind of a scoping review or a systematic search, which will help us to identify the gaps that are there in the literature and see whether the question that is there in the mind of your supervisor, are there answers for that available in literature, or there's still gaps? And what are those gaps? Can we actually specify and be more, threadbare them out? So that would need a lot of brainstorming with your mentors, going back to your review, and then re-reviewing your literature to narrow down on a focused question. So just to take you down the roadmap, as I said, we first identify our idea or a research question. We then put them through a filter. Now the filter here is that we look at something called a finer criteria. Is it interesting? Is it ethical? Is it feasible? Is it, so F is for feasible, interesting, novel, ethical, and relevant. Very, very important points. In your particular setting, does these filters work? Does this research idea, addresses or, goes through this filter and addresses these criteria? And then you would like to address few points on whether you do have that kind of population in your clinical setting. If you are planning an intervention, what are those interventions? Do you really need a control or a placebo or some kind of a standard of care to compare with? Is it really important for you to compare, or is it okay not to have just to observe something? And then, of course, what are the outcomes that you really want to focus your research on? What is the answer that is precisely your primary and your secondary outcomes, and the time frame on which you would like to work on? Especially if you're working on a thesis, you would have a fixed time frame. And after going through these filters, we again, defining the PICOT criteria, or maybe the PICO criteria, or whatever criteria you can specifically, you would then again put them again through a filter of finer criteria. So then what you have is a good research question, which is there. And once you have a well-defined, clear research question based on a thorough literature search and putting through all those criteria and filters that I talked to you about, now is the time to choose the correct study design for your research question. It's very pertinent that the research design that you choose for your question should have high index of reliability and validity, and should have the propensity to be generalized to the clinical settings on a whole, so that they can be utilized for clinical benefit, right? So why are we, talking about that? Because as we all understand, whenever you have a study, you're basically either observing some phenomena or some kind of, factors that are occurring, some risk factors, or you're measuring some interventions, the effect of some interventions. You have to understand that when you look at what you want, that is your outcome. So we have two elements. We have a measure, a kind of an intervention or some kind of a variable which is there, and then another is your outcome. So in between these two, there would be many factors that would be affecting what your outcomes would be. So those would be called confounders. So do we really? What do we really want to do is we need to look at a study design that will help us measure, understand, and control our confounders, provide us with objective and a reproducible methodology, which can be acceptably conducted ethically into your clinical settings, And of course, after you collect your data and analyze it, can be logically interpreted so that the study's reliability and validity is always maintained as you do research. Remember, you're doing research on human subjects, and therefore it is important that we adhere and think about all of these aspects as we comprehend and design our approaches. So just to give you an overview, study designs can be, classified as quantitative and qualitative. And what we do most of the time is quantitative research, which again can be observational and experimental. I believe experimental is something that we do more often in anesthesia. We do a lot of randomized control trials or non-randomized control trials. But there would be areas, and of course, recently me and my team, and I'm happy to see Dr. Mayank in the audience as well. He is one of the finest researchers we have in AIIMS Bathinda. We wrote an article on how to go about research into regional anesthesia. Of course, I would even say the similar pertinent points would be there for, say, on CPR or in pregnant patients and sometimes in children. So, you cannot always make a randomized control trial up there. So it's very important that we, find out other ways to look at good ideas, novel ideas, and research questions that could fill into the into the format of descriptive studies or analytical studies. Descriptive studies are, of course, as we all understand, case reports, case series, more than 3 rare things happening. You want to report them. They are one of very important, part of your literature because they provide you with research hypothesis and, of course, surveys or cross-sectional studies. They would either come into descriptive as well as an analytical part. And of course, you can have observational studies which can fit into either case control or cohort. So it's very important for us to understand, as I said before, what is a research question? What are we trying to find out? If you look at the qualitative part, it basically pertains to subjective phenomena, feelings, attitudes, emotional responses. And therefore, you need a qualitative research paradigm, right? And these are studies that will help us to understand that problem in depth, explore it, and describe it much better. The topic that is under study before you actually embark on a quantitative design. Now, just to understand what they are all basically all about is to understand that what kind of study are you looking at? Are you assigning exposures to your subjects? If the answer to that is yes, that means I am giving, as a researcher, providing the exposure to the patient, doing an intervention to the patient. It's an experimental study. And this exposure can be provided in a random allocation method or on a non-randomized method. And therefore, you have your randomized control trials and non-randomized control trials. On the other hand, as I said before, observational studies where you're not assigning exposures, you're just observing. For example, you're standing on the side of the road and looking at a lot of banana peels lying on the road. And you're looking at how many people are falling and what kind of people are those who are falling. You're just observing. You haven't placed the banana peels. So that's an observational studies. And do you want to compare? If you do not want to compare because you just found a particular rare occurrence, of a very big fit athlete falling across a banana peel. So it could be a case report, a case series, or a descriptive study would fit into that. Or else, if you want to compare it with some kind of a matched control, then it would be labeled as an analytical study. And then, of course, there are 3 types of analytical studies, which will again depend upon the direction in which you are measuring. So if you have an exposure and then you're measuring an outcome, either prospectively or even using historical controls, it would fit into a cohort study. Cohort studies are the highest strongest evidence in observational trials. Remember that. But if you really want a very small, study and you do not want to go very long and don't have time, you just want to pick up your data from your records and do it. So you have an outcome, but you want to find out how this outcome is this some kind of an association with the exposure. Now you go retrospectively back. That is what is known as a case control study. And then, of course, I further do not have a time. I just want to look at the exposure and the outcome at the same time. It's kind of a snapshot. Just want to look at the prevalence. That is where a cross-sectional study would come in. So you will have to first understand your research question and then fit it into either of these parts and of this algorithm and decide what kind of the best study design that it best goes through. So I believe I kind of addressed my entire talk up here. Let's just go through a little bit of telling you the strengths and weaknesses of each of the methodologies. So for descriptive, as I said, case reports and case series, more than 3 case series usually are either novel events that have happened or unusual cases. There's no hypothesis testing, there's no comparison group, but they have a beautiful thing that they provide you with a hypothesis that you can in future test on a different clinical trial. On the other hand, the analytical will always contain a comparison group, and they help you to assess some kind of risk, temporal association of risks, or association between the measure, the kind of the outcomes and the measures. So the study factors and the risk factors and the outcomes. So they give you, and based on the which temporal direction this trial works, as I said before, it could be either cross-sectional, cohort, or the case control study. Now, sorry, just to give you a few examples for especially the new learners. Cross-sectional study as one of those who look at prevalence of a disease. You want to find out, now since there is a COVID going on and there is a lot of exposure happening into your community, you want to find out the prevalence of the disease. So you have healthy as well as people who have COVID, and then you can at the same time look at their exposure. So it's a kind of a snapshot that gives you. One of the examples that are there on my slide is measurement of serum cholesterol in men admitted to the hospital with myocardial infarction versus that with a healthy next door neighbor at the same point in time. And therefore, you can kind of get a measure of how this prevalence, but this has its own limitations, its own issues, because will not always be reflective of the true prevalence of the disease. It will all depend upon how and where and how much of sample are you picking up, and are the controls really matched for the people who already have the problem that you're trying to find out. A cohort study is something, as I said, that you would like to, that there is some kind of a risk factor or some kind of issue up there, and therefore you want to look at the outcome over years. So it could be, concurrent as well as non-concurrent. And case control study, as I told you, will be more of retrospective studies. Retrospective studies are good, they're quick answers, especially when you have a promotion due up there and you really need, or I would say a paper up there, or you want urgent answers, and especially in terms of suspected harm in case of in our specialty. So this would be a very practical choice in these kind of research questions. So for example, there is a localized cluster of cancer in certain area, and then you want to look at you want to see what the outcome measure and the exposure measures are, and then you would like to find out what it is. But the problem here is that because it's a retrospective, there is a lot of bias coming in, because it may either have a recall bias, or if you're picking up records, there could be, especially in case of retrospective cohort studies, the records would not be accurate. So therefore, though you are trying to measure the odds of association between outcomes and exposure, and the exposures are spontaneous, you haven't inflicted the exposure up here, they could definitely not always be true, very accurate for you, right? So there would be biases coming in. And therefore, as I said, one of the best observational studies are the cohort studies. And they are one who answer your questions, especially on prognosis, on risk factors. To give you an example from anesthesia. So if I want to understand, why do mothers who are administered, spinal anesthesia during cesarean section have hypotension? I want to understand the entire, the main factors up there. So what do is that I recruit a representative sample of the mothers who are undergoing cesarean section, elective cesarean sections. And then, I also that's a sample that has had hypotension, and then a sample that has not have hypertension. That would be a retrospective. I go retrospectively and look at the risk factors. What were the risk factors? And of course, I'll have to rely a lot on the accuracy of records. On the contrary, I can go prospectively. So I can actually pick up a sample of patients and then follow them over a period of time, say during their stay in the hospital, and look at factors that have led to the outcome. So some kind of studies which basically more I would say more often look on prognosis and risk factors. But the problem is that they are of long duration, they're expensive. Most of your patients would be lost to follow. The example that I gave would be a very short study, and of course would more fit into a randomized control trial than a prospective cohort study. So, sorry. And of course, as I talked to you about cross-sectional study, I'll not get into the details of that. But the strength of the study is that you can actually at times pick up numerous potential, multiple risk factors in a single study. And that is the, a kind of strength, whereas the weakness is that it is usually, the data collection is usually based on questionnaire surveys which need to be validated, and there is always a scope for errors and biases. And the last and the most widely practiced, as we all understand, are the randomized control trials and the non-randomized control trials. And as we know, randomized control trials basically ensure that the participants in both the arms, where an intervention would be done by the researcher, are actually assigned to both have a minimal chance of bias coming up, whether it is a selection bias or an observer bias. So you are trying to reduce the confounders and the biases that are there in these studies. So you are trying to have assignments based on randomized various methods of randomization that you would use for putting them into, and of course try to make them as much valid as well. And there are multiple types of randomized control trials. There could be crossover RCTs. One of the examples of a crossover RCTs is trying to assess two different methods of bag mask ventilation. Say I want to assess efficacy of bag mask ventilation using a EC technique versus a VE technique, or say a hybrid technique. So, and I want to assess them on a novice provider. And therefore, rather than have multiple patients and on which they all go and keep doing it, I can have a standard patient and then have a crossover. But what we have to remember that between the crossovers, when you move from one technique to another, in this particular example, you must have a period of washout or a resting period where the effect of the previous one has been, a kind of lessened out in whatever aspects you can decrease the effects coming in. Then, of course, there are multiple. Now, of course, we are into an era of non-inferiority trials, RCTs, where the newer intervention is less effective, but is kind of traded off for other advantages like low cost or safety. So it's an active comparator, but it kind of performs well with the standard of care, right? And then, of course, I really want you to take your attention is to the pragmatic RCTs. They are real world studies. They have a great generalizability. They can have great external validity, but of course, they will, as we understand, because they're real world studies, they will have less internal validity. There would be a lot of confounders coming in. And as new drugs come in, we also need to understand what are phase 1, 2, and 3 trials, especially when new molecules hit the market. We need to understand that phase 1 studies are something that are conducted after the safety of the new intervention has been tested on animal. And now you want to document the safety of this intervention on humans. So it's usually performed on healthy volunteers. So it's very, very rigorously and meticulously conducted. The phase 2 studies, they are providing us information on safety, but they have started now to focus on efficacy of that molecule. And then, of course, our phase 3 trials, which basically look at effectiveness of that particular intervention or that molecule or the device, whatever in question is. And we of course, we need to look at mainly as a primary outcome, the effectiveness, but of course, we also at the same time keep looking at the adverse effects, the safety profile as well. And so most of our randomized control trials, that clinical trials that we do are basically phase 3 trials. Phase 4 trials are post-marketing surveillance, where you actually report, monitor and report adverse data. And then of course, there would be times where you cannot have an randomization coming in. You cannot allocate a pregnant mother into one arm, especially, when if I want to do a study on maternal CPR, I just cannot allocate that. I will take one mother to the operating room and do a postmortem cesarean delivery, and on the other hand, do a PMCD at site and look at the efficacies of both. So this will not be possible. So in that case, of course, all this kind of experimental trials would be off. We would actually rather have an observational trial coming in, or can have a non-randomized control trial coming, especially in cases of regional, newer novel techniques of blocks coming in. So you want to compare it with the standard of care. So that is where you can perhaps, at times where ethical concerns are pretty much there, we can go in for non-randomized trials. So just to give you a recap, RCTs, as we all know, we do it more often. There is an exposure and an outcome, and you also look at the adequacy and you try to control the confounders as well. Whereas in a cohort, we do look at the exposure and then the outcome, but the confounders, though we try to balance them, there still would be many that would be lurking around, and then therefore you might need a statistical adjustment for the same. Whereas in case control studies, you're actually looking at the outcome and then going back to look at the exposure. So there would be a lot of errors and biases coming in, and confounders will always be there to actually make your study not that valid and accurate if you were trying to look at this aspect of the study. So it's very important to understand your research question, where does it fit in, and then of course choose your correct design. While choosing not only on these particular aspects, it is also important to remember to look at your clinical settings, to look at the ethical feasibility of your study, the ethical nature of the study, and of course the expenses, the costs that are incurred, everything together, along with the research question, which is the backbone of your research design, is how you would continue to choose your studies out of these, and therefore embark on a good research, which will may give you better valid results and higher chances of getting published in citations. Thank you so much for your patient hearing. Would love to have questions and of course comments and inputs from all the experts.
Thank you, Dr. Anju. It was a very informative lecture, I must say, because having a study design or a robust study design is the ultimate. If you don't have a good study design, an article would never be published, or its relevance is really gone. Thank you for highlighting that. And I think there are some questions which have been put up in the chat box. One of the questions which initially came was, for each one of them, the observational, the analytical, the randomized control trials, they wanted an example from anesthesia. Is it possible to give at least one example to each of these study designs in another 5 minutes or so?
So for observational studies, I would say, as I told you, looking at, say I want to design, as I gave you a last example of maternal CPR, and I want to look at, say I want to look at location of postmortem, or the number of PMCD, the perimortem, or the hysterectomy interventions that we do. We have recently introduced the term resuscitative uterine intervention. So I want to look at whether these resuscitative uterine interventions really perform better when done at bedside or in the operating room while we are doing a CPR, and is there any mechanism where I can, kind of get this patient shifted. So I will not be able to plan a RCT for this particular question. So it would be best to observe, have a kind of a observational study, for that, as and when these patients come in. It would rather more fit into descriptive, kind of data up there, because it is not something that I can decide, So that is some kind of an example that I can give it to you. Regional anesthesia, for that matter, you're planning a new So you're kind of planning a new intervention or a new block that has come into the picture. But there is a standard of care up there for that particular block. So when you want to do it, and especially if your study population in question is, say, a pediatric group or an obstetric group, I would rather, have more of start off with descriptive and then move to observational, and then of course later on come to balance it out to come to a controlled trial. I hope I have kind of tried to answer a few questions here and there. I would like to have inputs from researchers on the.
Anyone else would like to pitch in?
Put in more, yeah.
Please raise your hand so that we can allow one person at a time. Anyone?
Pankaj sir,
Yeah,
there are comments in the chat box, sir.
Yeah, I'm putting up a question which the chat box, in the chat box, which says that can we have some examples relating to anesthesia of the different types of study designs. So Dr. Anju has given a couple of them. If anyone else wishes to pitch in, please, most welcome. Please raise your hand so that I can give a chance to each one of you one by one. Rakesh, you're not audible. Okay, you are muted if you're trying to say something.
Dr. Prakash wants to say something.
We couldn't hear you, Rakesh.
Dr. JP wants to say something.
Dr.
Yeah, please.
Jayaprakash. Okay.
Dr. Jayaprakash, please. No. Okay, the other question is, can you please give some examples in crossover RCT and non-inferiority RCTs?
Yeah, I did give you examples about crossover RCTs, one of a very easy example is, I remember this example because I had a problem with my ethics committee over this. So we were trying to compare, say, a technique of bag mask ventilation, two different techniques of bag mask ventilation using novice providers in, of course, human subjects who were easy to ventilate. Right? So with due training and everything, we wanted to see how does this particular novice provider perform a particular technique, say a EC clamp technique versus a VE technique in the same subject over a period of time, right? And then look at variables, especially the exhale tidal volume or whatever. So the best method up here is that we do it on the same subject. We first let the provider do one technique, give a breathing period in between, and then of course go on to that. And as Dr. Jayaprakash has written, we can have a pilot trial to look at how efficacious this method is for this particular research question. And so therefore a crossover happened in this particular group, and that gives you a better measure to understand the efficacy of both the techniques in this, because I haven't changed the subject. So there could be, I've tried to reduce the bias or the confounders coming from using various subjects. That's where perhaps a crossover study would perform good.
Dr. Jayaprakash, please.
We also have Dr. Narayana up there, and would like them to be unmuted.
Dr. Jayaprakash, please unmute yourself. One by one, we'll give them the chance. Yes, Dr. Jayaprakash. Please unmute yourself. You're muted. Okay. Shall we come back to you later? I think there is an issue. Dr. Murlidhar Joshi is there. Sir, if you wish, you can unmute and please give your comments.
I think the host will have to unmute them.
Yeah, I think, thank you so much, Rakesh and Dr. Pankaj and Dr. Anju for sharing these thoughts. And right, it's very important, probably, the more we hear about this one is good, but question is about the, what are the discussion was there about the RCT and all those things, like, we have a different kind of observation with respect to, I should say, say for example, we do the lot of digital spine for the or maybe for that matter, degenerative joints also, knee replacement. Say, for example, how much time it takes to give a subarachnoid block just by doing it like the way surface landmarking versus if I get an X-ray beforehand, and in case the patient had a scoliosis or kyphosis, maybe I'll take less time. Where do you quantify this one, Dr. Anju?
So
I hope you
it
got my
is-
point.
Yeah, I understood. You're basically trying to say that you're trying to compare the time taken to put in a successful subarachnoid block, for example,
Yes, yes,
using
yes.
either a conventional landmark versus you have some kind of, say,
If the X-ray or maybe ultrasound, that's
an
okay.
ultrasound. Yeah. So since here you can kind of plan a trial which can be a a kind of a randomized trial, but of course you will have problems in selecting your subject. So I would rather have I would rather like to have more inputs coming
No,
in.
because we are doing it regularly. No, because we have found that one because even it takes time and also like that doesn't matter. But question here is if they do knee replacement, they take an X-ray. Without doing the X-ray, they don't take the knee replacement surgery. In same patient who had degenerative spine, so degenerative knee joint, they also might do degenerative spine. So we should ask for not only X-ray just in PSC. You should also ask for X-ray spine. That's the whole
So
idea.
can you change your question rather than measure the time? I would rather like to look at the how easy was it to put in when you were guided by a particular, so the ease would be a more. So this is more of a, study that comes in with a lot
Or
of.
maybe all subarachnoid block should have an X-ray spine, not only just X-ray chest for PSC. We propose
What I can do for this particular study is make a cohort, and a cohort would be one. So
no, it's fair enough.
Prospective cohort would actually
I'm just
work
sharing
well
as a professional colleague. I'm just asking your guidance. Why I'm asking is, we keep on asking all the PSC and all those things. Where you plan for professional, like regular subarachnoid block? Can we ask for X-ray spine? Is what I'm asking you. Because it's a basic, simple study for any postgrad student.
Dr. Murli, if I can intervene, you can definitely ask for X-rays, but the ethical committee will have to give you an clearance, and you will have to justify why you are exposing all your patients for an intervention like an X-ray. That's all. If you can convince the ethical committee, and if they give you clearance, then you can go ahead and do that for all your patients who are undergoing an intervention.
Sir, right, sir. But what Dr. Pankaj is also want can I do an ultrasound for this one for same patients? All subarachnoid block.
Sir, whatever intervention you plan, you will have.
I got it, Pankaj. I got your point, Pankaj. I got it. Fair, Pankaj.
Dr. Narayanan, if you can please unmute and please.
Yeah, good evening, sir. Can I ask my question? Yeah. I have two questions. Good evening to all. Yeah, sir. My first question is that on the basis of our pilot study, which study design should we proceed and which will be better to see the outcome?
Okay. Can I say something?
Yes.
Is that okay?
Yeah.
Okay. So
please go ahead, Dr. Narayanan. Sorry.
Yeah, I'm basically addressing the thing that Dr. Muralidhar raised, right?
Sir, मैं छोटू मुरली.
Murali. Okay.
What Murali? Call me Chotu. You're Chotu. Yeah, please, sir. Please go ahead, sir.
My point is basically this. You are assuming when you ask a question like, should we ask for X-ray chest, X-ray spine for all the patients? You need to establish that there is a benefit first. Okay. At the moment, we don't have any evidence of that sort. You will need to establish benefit. After that only you can do anything else, right? Okay. So if you want to study this, the outcomes don't have to be the time taken. They can be multiple. You can talk about using only landmark technique without any information and radiological information. Another group in which you use only radiological information. Another group in which you use ultrasound information. And then you would look at the outcomes such as time taken for establishing a subarachnoid block, the first pass success rate, blood ETAP, or things of that sort. You can have multiple outcomes. You can look at each of those things, establish that any of your methods is actually beneficial before you ask for that to become a standard practice. Okay, that's what I wanted to say.
Thank you, sir. Thank you, sir. Thank you very much, sir, for that one.
The other thing I wanted to say was give an example of a case control study that one of the audience have asked for examples of different types of studies. I wanted an example of a case control study. For example, in pediatric airway surgery, pediatric surgery in general, you might have a certain percentage of patients having developing laryngospasm post-operatively, or on the table, or post-operative in the recovery or whatever. So in a cohort study, if the percentage of laryngospasm is say 10% or something of that sort, you might take a long time to recruit enough subjects. So in that sort of a case control study would be ideal. You can choose that you identify the cases, that is the children who have developed laryngospasm in the postoperative period, and then in the same time period you go back to your records and find matching children with similar diseases who have had similar surgeries, who did not have laryngospasm, and then you can go backwards to see what are the things that predispose these people, the one group to have laryngospasm, another group not to have laryngospasm. This would be an efficient way of getting some amount of information out of the data.
Ma'am,
yeah. So basically, you need to look at outcomes which are not very common. That is where your case control studies benefit most, where you find relatively rarer outcomes, and then you want to figure out why those rarer outcomes have occurred. Right.
Something like prognosis, as you said, we have had some bad prognosis, so we can perhaps find a matched control and go back and have a look at.
Thank you, Narayan, and so nice of you to pitch in. Dr. Rakesh, you wanted to say something?
Yeah, I just want to clarify one myth which many of the people has when Dr. Narayan was talking about case control. He rightly has explained it. So just to remind everybody that case control is not a study where you have a group called case and a group called control. So many people, when they have a parallel group study, even sometimes it is an RCT, so they will put it as a case control study because they say one is a case group and the other control group. Dr. Narayani has mentioned it very clearly, so I think that will be an important one, number one. Number two, case control studies are the retrospective one, where he rightly mentioned that you're looking for some rare disease or rare outcomes that needs to be looked for. Over to you, sir.
Thank you so much, Rakesh. Okay, there is another question. Is it necessary to register COSI experimental studies like RCTs and with CTRI? Yes, it is mandatory that you have to register all your studies with CTRI. So I've answered that for Anju.
Thank you.
Okay, Anju, the next question is.
And sir, just to add on, I think ISA has now taken a decision that all studies which are CTRI research prospectively will only be considered for further process. So please do care. All studies must be CTRI research. CTRI is one of them. You can register in any of the.
So the benefit of registering, why it is mandatory, is that you do not change your primary objective depending upon the results which you have got, and you do not redefine your methodology after the study has been completed. So everything is locked. That's the reason why all that manipulations which used to happen earlier have been stopped. And that's one reason why CTRI registration is mandatory for all studies. Fine. There is another question, Anju. The question is how to do an observational study on regional block, that is standard versus newer technique in pediatrics.
So basically, I would actually like to first look at the efficacy to understand the efficacy of that particular block, the newer block that is coming in. The best way is to have a kind of a a kind of a cohort study where you are subjecting a few patients who fulfill the criteria, of course, as I talked to you about feasibility and all those issues. And then you pick up your subjects and you put them to, you have already a measure, a kind of an outcome that you have already defined up there. And you give them that block and you look at that. And at the same time, there would be an equal number of similar age groups of pediatric patients who are getting a standard of care block up there for the same procedure. And then you would look at their outcomes. So this kind of gives you a more of an observational. You need not, allocate them into different arms because of ethical concerns that might arise from your ethical committee at times. So that is one way to look at, do a prospective cohort study.
Ma'am, may I ask one question?
Yes, yes.
Yeah, Dr. Jayaprakash here, ma'am. Ma'am, many times we are presenting our trial in IEC, and their layman is asking about simple question. So that doctors have, if something will happen to the patient, then who will give compensation? Then I asked this one to my director. So he said, because I didn't get accurate answer for that. Suppose that if we are doing a trial, definitely side effect can be happen. It may be lethal also. So who will compensate? Our ISA society?
So Dr. JP, I think this question is out of the view for today's discussion. Definitely, I think this is a very good topic. Sometimes we'll come up with the ethical approvals, the clearances, and the ethical and medical legal dilemmas in subsequent sessions. And we'll keep it in detail because there are many concerns which talks about the insurance from the institution base, sometimes from the external agencies. So I think your question is good, and we will definitely keep it as a separate full topic so that everybody gets a full exposure to how to take studies where you are exposed to certain risks.
Okay, Dr. JP,
Okay.
just overriding what Dr. Rakesh has said as a chairperson, just in 2 lines. Sorry,
Yeah.
Rakesh, I'll just satisfy him. It's all institutional policies, Dr. JP. Like for one institute, the institute may say that whatever happens to the patient, all free treatment and everything would be given by the institute because something has gone wrong in that particular place. So the institute owns up this responsibility. But definitely, as far as financial gains are concerned or financial aspects are concerned, institutes do not go into that. That's a general policy which is followed by most of the institutes. If something happens, we'll give them free treatment to manage that morbidity, what has happened due to something, but there will be no financial implications. You can't demand 2 lakh, 5 crore or something like that from an institute. So just for the PG dissertations, I'm just highlighting that.
Pankaj sir, shall I further comment on this one? This one actually, Nishant also.
Yeah, Dr. Bajwa, just 2 minutes. Let's. Sure, please go ahead.
Yeah, the thing is that when you are already showing this consent form into the ethical committee, the ethical committee is a representative of the institution. So whatever the ethical committee has agreed upon, that is being agreed upon by the institution, and the researchers are just the employees of that government institution or the private institution. Institutions give the go-ahead to them after giving the ethical clearance. Institution also becomes a party to the research. Regarding the financial implications, it's not about the person who is doing the research, he has to bear the thing. Institution is also insured because the professional indemnity, the research indemnity is also there nowadays, where the institution, because the things, all the educated people, Dr. J, in the ethical committee, there is nobody who's a layman. In ethical committee, everyone comes from a specialized branch, and there is an advocate, there is a legal man also sitting there. There is a chairman who is a non-institutional person. So everything is being considered in entirety before we proceed for the research.
No. In our
that.
ethical committee, simple person from our society, and they are even only matric pass. They are also sitting there to ask that kind of question.
There is
and they are asking still.
Yeah, Dr. Jayaprakash, there's a constitution of an ethics committee. An institutional ethics committee is supposed to have, as Dr. Bajwa very rightly pointed out, a person who is a social person, a representative from the society, who, as you would say, is a kind of a matric pass, also a lawyer and everything, and there would be caveats and a prior, beforehand, the institution should have policies on how to, protect. And also institutions do have a committee that monitors adverse events that happen. You need to go back and report to them as well. So that is,
Exactly.
there has to be a policy ahead of, when you formulate your IEC, which takes care of all of these aspects.
Okay, thank you, Dr. JP. The next question is Dr. Anju. This is regarding the Cromac-Lehan grading after using Macintosh and McGrath blade laryngoscope. He says crossover. I think basically it's to confirm whether it's a crossover design. Of course, if it is in the same patient, it is crossover, but again, subjecting the patient to 2 laryngoscopies is again a matter of concern, and you will have to justify why do you want to do 2 laryngoscopies in a patient, and the ethical committee would take up this question.
And indeed, sir, when you're looking at 2 different devices, you can perhaps have 2 similar kind of patients. You can choose your subjects in a manner that they have the same kind of, say, airway features, or you kind of difficulties up there, and therefore look at the efficacy of both of them in different subjects. So this is
rather
not
than having a crossover after some time.
Yes.
Okay, there is another question from Jay Prakash. Is it good to make our research questions from systematic review and meta-analysis and then proceed with our study designs? Because making research questions from systemic review and meta-analysis gives better gap.
I believe, yes, systematic reviews do give you a better insight into the topic that you were planning to look at. Maybe, so a meta-analysis might give you a different direction altogether, because you would be, looking at the efficacy of the particular intervention that you are trying, or the studies that have been done on that particular intervention. But it is not necessary at all the time that you do a systematic review. There could be times where a research question can be done on just a scoping kind of a review of literature, where you look at what is available on that particular topic.
See, Dr. Jayaprakash, this question looks like you are looking for a research question. Actually, the research question, you should not be looking into the literature to find a research question. It should come from your personal experience that these are the things which we are having an issue about, and we want a scientific method to prove that whether this technique is better or not. I mean, those things should have, rather than searching the literature to find a research question. Okay, next one is examples of qualitative study in anesthesia.
So one of the very,
please switch off your mics if you are, please switch off your mics. Yeah, Dr. Anju. Examples of qualitative study.
So, kind of want to look at, most of the satisfaction surveys, the experience of the people. So quality data that is coming in can, of course, be safety data, not exactly the safety data, I would say, but then satisfaction surveys, or you have a patient who has had a post-traumatic stress disorder following, say, you want to look at a polytrauma victims having, what are the kind of stress disorders that they have over a period of time. Perhaps a qualitative analysis of understanding those more of these questions would give you more insight, and then perhaps you can embark on different kind of studies later on. So these would, to my mind, be qualitative studies.
Okay, Dr. Anju, another question. Most of them are related to CTRI and all, which you have already answered. So yes. I would go to this one. Suppose we want to compare feto-maternal outcomes in patients undergoing lower uterine cesarean section between spinal and general anesthesia. Is it observational or interventional?
I would rather have it observational rather than do an interventional, where I subject a group of mothers to general anesthesia deliberately to look at fetal-maternal outcomes, because there would be ethical concerns up there. We all know that there would be concerns of general anesthesia or inability to, airway being one of the most important ones. So matching these 2 subjects would be, and of course, it is something like trying to compare 2 different techniques altogether for outcomes. So an observational study, a large prospective cohort would be a better way to look at this particular outcome. Am I
So
right?
Dr. Suman, the way to go about is that you choose the indications for giving general anesthesia. Suppose it's nice one or patient has denied spinal or something of that sort. And if your inclusion criteria is good, it can still be an observational study where the defining of the patients going to a general anesthesia or spinal is defined initially. So that can be done, and it will be an observational study. What happens to the to the feto-maternal outcome under these two categories? Okay, next is. Can we also have a quick comment from Dr. Mayank Gupta, as he did raise his hand? Dr. Mayank Gupta. Sorry, I didn't see your hand here. Please raise your hand and then you can unmute yourself and please reply.
My apologies, sir. I raised my hand in response to the question about the crossover and the non-inferiority trial. So I think so that has already been answered. Thank you.
Okay, thank you. Any other questions? Ethical concerns, I think these are all about the questions. Okay, Dr. Anju, couple of things perhaps if we can, I know it is probably out of the context of the present topic, but I think in randomized control trial, they will talk about consort flow diagrams and other things and intention to treat and per protocol interventions. I think that will be called together. So if there are any other more questions, if anyone wants to ask, please go ahead and ask us before we wind up, because it's almost 6 o'clock now, 2 minutes to 6. Another one question.
Pankaj sir, there are 2-3 more questions in the chat box.
PG is allowed to do interventional study, or they can do only observational study. They can do either.
They can do either, right? Next. Ma'am, can you please give examples in crossover RCT and non-inferiority RCTs? I think this you have already answered, Anju.
Yes, sir. So one thing, CT, I would just like to highlight also here that, you know, when you're designing your research question and your study, you're kind of formulating your, I would say, a research question, and then of course designing your study. Also look at, you know, there are checklists available that look at how do they, objectively quantify or, you know, critically evaluate your papers or your study designs. So there are enough checklists. There are, as Sir said, checklists, a consort flow, a checklist how to report, our RCT or an observational study. There are stroke guidelines. So you can go on to them and have a look at them, understand whether my research question would be able to, you know, stand that critical analysis also as well. Using this particular study design perhaps can guide you further to, before you embark and go on to your ethics committee and get your approvals.
Thank you, Anju ma'am, for lucid presentation. You mentioned non-randomized controlled trials in one of our slides, in one of your slides. When is it acceptable not to randomize in a controlled study?
So it is always better to have randomization coming in, because then you're able to remove selection bias out there. But then there would be a group of patients where there would be ethical concerns which would not permit you, as I wrote up there, randomization. That would be one area where I would not do a randomized clinical trial up there.
Okay, Dr. Anju, if we don't have a control, can we do a comparative study also? In what category would it fall down?
So what are you trying to compare it with?
Maybe 2 devices.
Yeah.
Let's say two video laryngoscopes, and then it's kind of a comparative study rather than having a control.
Yeah, definitely. You can do that, but then you need to define what are your outcomes? What would you actually want to measure from them? That has to be very precise. And then, of course, your secondary outcomes, which should include safety issues, because these would be devices that you're using on patients.
So what is the difference between randomized clinical trial and randomized control trial?
Most of the times they are kind of, I would say clinical trial is a kind of a trial that you use for clinical scenarios. A control trial, I believe it could be used synonymously most of the times, but then in a control trial, you are actually controlling the confounding variables as much as is feasible to you. That is what my understanding says. I would like more light over this question there. Because you do have a randomization coming in.
Later on.
Of course, you have a clinical setting in which you are doing a study.
Are PGs allowed to do interventional study, or they can do only observational studies? No, they are allowed to do interventional studies. A lot of PGs do that. For doing dissertation, who will be the principal investigator, guide or student? The principal investigator has to be the guide. Okay. Anything else? Where ethical concerns do permit randomizations. That is your answer. I think that's 6 o'clock now. Can we wind up, Dr. Anju? It was an interesting topic, and I believe a lot of
snapshot.
lot of learning has to go, especially by the PGs. The number of PGs have increased exponentially, and everyone is looking for a thesis topic, and they must get well versed with the study design, because that's the most important aspect when you want to do any research. If the study design isn't robust and it has not been designed well, there is least possibility of it getting published. Thank you very much for such a lucid presentation. Thank you, Dr. Bajwa, Dr. Rakesh Garg, and all the eminent faculty and our colleagues who are present online. Thank you.
Thank you so much.
Thank you, sir. First, I will tell you that because this recording will be available on the YouTube also at the ISA-IJA YouTube channel. It will be available tomorrow, and it will be available on the ISA website also. I think Dr. Rakesh should conclude this session.
So thank you so much, sir. Thank you, Dr.
So Rakesh, just one suggestion before you conclude.
Yes,
if you give us a list of 2-3 topics, so we at least come to know that we are not spilling over to the next topic and it can be discussed later, like someone talked about the ethical considerations. So we will be prepared not to, even everyone would be prepared that these questions can be asked in the next session or some other session. Thank you.
Sure. That I prepared the series of topics, sir, and we'll be sharing with everybody, all members also. So thank you so much, sir, for chairing this session and having such a fruitful discussion. And thank you, Madam Dr. Anju Grewal, also for a very interesting talk, which she had made very simple through her slides. I'm sure there will be many questions, and all the experts will be available. If you still have any questions, you can always share with us, and we will try to plan in some way that all your questions or queries will be solved in subsequent webinars also, which has been discussed in the past. And these webinars will be happening alternate Thursdays at 5 to 6 p.m. So please join, and do share the links to your residents also at various places, so that at least a good research, because we have a lot of source of doing researches from India, such a big clinical case load, and we can do wonderful by reporting them in a more methodological way. And this series of cases or this series of webinars will be helping. So thank you once again to everybody, and see you next Thursday at 5 p.m. Thank you so much.
Dr. Tejkal sir is there. We should listen from him his word of wisdom. Yeah, he has been sitting right from the beginning of the class. Sir, unmute yourself, sir. Call, sir, unmute.
Thank you. Thank you. It is always a pleasure to hear to Anju. And the session was excellent and superb, particularly the moderation done by Professor Kundra. Even at this age, I still continue to learn many things. The time is over, otherwise I had some points to say. However, it was an excellent session, I love to attend to these sessions which are primarily meant for the beginners who have just joined the PG. Thank you very much. Thank you all. God bless you.
Thank you,
Thank you,
sir.
sir. We missed you, sir. You can add on whenever you want for all your experience and knowledge, sir. You're full of those experiences.
Thank you. Thank you. Thank you.
Thank you, Dr. Bajwa. Thank you for all the help.
So
Thank
shall
you,
we say
Tejpal, sir.
goodbye,
Thank you so
goodbye
much.
to everyone? Thank you, Dr. Anju, Dr. Pankaj. It was a wonderful session, and I think this IJ session will keep on growing in the coming days, and more PGs, as pointed out by Dr. Pankaj sir also, we will be having more PGs on this platform. It will be beneficial to all. And as echoing the words of Kaul sir, it was an excellent presentation today. And with this, we formally conclude today's session. So we end by saying, long live ISA, long live IJ, Jai Hind.
Jai Hind.
Thank you so much.
Jai Hind. Jai Hind. Jai Hind. Thank you.